Welcome to our podcast. I am Dr. Avinash Jayaswal, Chief Medical Officer of CCM Health, and I have the pleasure to have you with us for our podcast on health and regulations, friend of foe. I am joined by our distinguished guest, Dr. Baran Erdik, who is also our advisor on regulatory compliance, practice transformation, and value-based care. Dr. Baran Erdik, welcome.
Hi, Dr. Avinash. How are you?
I'm good. I will throw you the first question, and then the mic will be yours. What's new in the population health space? And as far as CMS, as this is your ballpark, please.
Sure. I mean, CMS is a topic on its own, right? So I think before we go into CMS, maybe let's just discuss the population health things that have been going around. I mean, first up is just the big obvious one, right? It's virtual care. It's been here since COVID. It is going to be here, and it is not going anywhere. Telehealth, telemedicine, remote patient monitoring, and all that good stuff. Ultimately, those are the big things that have been out there changing how care is delivered. It doesn't matter if you're in a hospital setting or if you are in a big group setting, or even if you're just by yourself in a doctor's office, right, Dr. Avinash? Like, it is just out there. Everyone wants to be seen virtually. So with that, the CMS has been that as well, that this is here to stay. And then especially with regards to value-based care, there is some concerns of overuse, but it is definitely here to stay. Sure. Another thing I guess we can mention is just the social determinants of health and how we can tackle these from a population health perspective. And that ultimately will all tie back to just chronic care management, because whenever we talk about this, it just boils down to social determinants of health, which then ultimately boils down to just the chronic care management and the chronic health issues.
Yeah, we'll come back to the social determinants of health, but something very, interesting with telehealth. How many people just hate being in a waiting room of a doctor? That's like, I mean, I'm talking about my friends and other people who are not in the medical world, So telehealth actually removes that. People don't have to go and like wait and take an appointment, wait. So, those are rituals of seeing your doctor, right? So yes, telehealth, has been pushed by the pandemics, just like so many things. And we'll get into more of that. So you mean to say that's the thinking is that they are going to keep that? Is that what you're suggesting? How
it is definitely here to stay because the feedback has been good, and I think, in my opinion, there is more. The more things you put on an electronic platform that includes EHR and stuff, from a CMS perspective, the more traceability there is. So they like that. They like the data. They like the bigger data analysis. So I think telehealth helps with that, because at that point, it is way easier to say, because everything's done virtually, why the patient was there, why he was seen. So I think I like to think of it as EHR 2.0. It's just the ultimate next step. So ultimately, in my opinion, these EHR systems in 5, 10, 20 years, whatever, will be just a one-stop shop, right? Everything will be in that ecosystem, all your lab results, all your doctors, and then you'll click a button and connect with the doctor, and they'll be able to see everything. And if you're one of those unlucky people that has a lot of chronic diseases, especially with the advent of long COVID on a population basis, I think this is going to be a lot more problematic. You're going to also have the chronic care management systems built into that.
Totally. I mean, value-based care finally is quality divided by cost. So, if we can remove a lot of those layers, which are maybe, just there and not really serving any purpose. So, yeah, I mean, going forward, the idea is to keep progressing, right?
Exactly. And then, that brings me to the driving force of the U.S. healthcare. That's been the triple aim, right? So improved quality care and patient experience at a lower cost of care while achieving improved population health. So that's ultimately the triple aim.
What about the waivers? Can you tell us a little bit about those? Which ones have specifically terminated, and keeping in mind our audience, what could be most relevant?
So the public health emergency, if you'll remember, was declared by the Secretary of HHS, the Health and Human Services, in about late January 2020, was it? God, it feels so long ago. That was pursuant to Section 319 of the Public Health Service Act. So that technically by law lasts about 90 days, but it's been renewed continually. So as recent as April 2022, but it's supposed to be expiring in mid-July 2022. So the administration said it will give 60-day notice before that expires. And a lot of it has started to expire, and they've been giving us notices. There has been also declarations and emergencies under the National Emergencies Act, under the Federal Drug Food Cosmetic Act, so the Emergency Use Authorization for FDA, as well as the PrEP Act, the Public Readiness and Emergency Preparedness Act. So what does this mean? This means that a lot of the things that either CMS or Medicare wasn't enforcing, maybe from coverage costs payments or hospitals, like every sort of thing. They are either going to start enforcing these or we are going back to the Waivers. So from a Medicaid and, from a Medicare perspective, basically there was no cost sharing for at-home testing. That's supposed to be ending. Again, for a lot of vaccinations and treatment coverage,
Sure,
that is probably going to be ending. From a rate and billing perspective, states were receiving federal match increased from a, 6.2% increase in their regular federal matching rate if they met several requirements. But from a hands-on primary care physician, or basically if you're actively seeing patients on a smaller office setting, the major changes are going to be how telehealth is delivered, basically whether these could be done with a smartphone in lieu of both audio and video. So you could have a telephone one only. And this was basically, again, what services could be provided and what services could be provided in which states. But on that note, I also think a lot of this is going to be staying. So just because the waiver is there doesn't necessarily mean that political push isn't there. So I think a lot of this is going to be staying even after the waivers are done. And one more important thing that I think clinicians should be ready for is that there has been a lot of Medicaid and CHIP flexibility, especially with people's enrollments and continued coverage. So basically, there may be a time where this is just canceled, the emergencies are no longer extended, and suddenly a lot of your patients may suddenly be uninsured. So you need to be ready for the transition when and if the time comes, because if these people are especially having chronic diseases managed by yourself, you may not be able to immediately discharge them, and they may not have the ability to pay for their care anymore.
So these waivers, we're talking about the big ones, or the skilled nursing facility, the nursing facilities, the end stage renal disease centers, but one thing kind of important, and you can take over that, is that you can file for like an exclusion or a waiver of a waiver, right? Can you, like, if your situation is specific, right, and the waiver is like maybe hindering your practice, or something is not, you're not ready for like implementing the waiver, the waiver being gone right away, there's the possibility to negotiate.
So it depends on which program or what you're talking about. For example, for MIPS, you can technically file an EUC exception, that is the extreme and uncontrollable circumstance application.
Okay.
So basically, you can request rebate of any performance categories because of an uncontrollable circumstance or the public health emergency. Same thing for the MIPS promoting interoperability, performance category hardship exception. So for some things, yes, you can. For other things, no, you can't. For example, the 3-day prior hospitalization requirement for skilled nursing SNF stays for Medicare beneficiaries who needed to be transferred was waived. But I don't think they will waive that again. That was just waived because of the pandemic, or for the kidney dialysis centers, there were staffing things that were waived because of the pandemic. I don't think you can get a waiver for that.
Yeah, totally. And some training waivers that, of course, were wartime situations, so that those are now being reinstated, right? What about the
Correct.
Medicare?
More level though.
Yeah. What about Medicare specifically? We keep hearing about new things coming out. What about the Innovation Center? Can you tell us a little bit of what's going on with them?
Sure. So basically, I mean, the way this has been going on is they like to try things, right? So there's no figuring it out without trying. So last thing they've done is they announced a new ACO Reach model to replace Medicare Direct. This was early March. So basically, they had redesigned the direct contracting model for 2023, and they were requesting applications to solicit participants for this new version of direct contracting. So they're going to be calling this the Accountable Care Organization, ACO, the REACH model. And REACH is realizing equity, access, and community health.
Mhm.
So basically,
determinants of
they
health,
are yeah, they're trying to align it with the purpose, right? What was the purpose? To encourage healthcare providers to coordinate care, improve care, especially those from underserved communities. So basically, they will begin this on January 1st, 2023, and then they will analyze how this goes and then whether this will be here to stay or not. Two things is that there are two volunteer risk sharing options. Professional, if it's called, it's going to be a lower risk sharing arrangement, so 50% savings losses with one payment option, the primary care capitation, so you'll be paid by per capita. Global will be a higher risk sharing arrangement, 100% saving losses, but you'll have two payment options, either total care capitation or primary care capitation.
Mm-hmm.
Basically, a risk adjusted monthly payment for all services.
Mm-hmm. So all this is in the context of the physician-based or physician network-based or ACO. Where do these changes come in, or both?
This is coming in for those that are on the Medicare Direct model. So this is what the new, like the Innovation Center is looking at.
Okay.
For a recent more, I guess we can also discuss about that. There was an op-ed in the New England Journal of Medicine,
okay,
I believe several weeks ago. So senior CMS officials basically wrote it with regards to changes to Medicare-sponsored ACO programs.
I saw that article,
what the future is going to be bringing. I don't know if you saw this or not, but
yeah. So there was another thing that was really hot on the pod last week was this meeting in Baltimore of the National Association of ACOs, and we flirted with the idea of going down there, but our schedule here in New York was just not possible to do it. But so one thing that struck me, what is obvious, was 10 years, and they had a big cake for it. There's always a big cake for like an event, right? So big cake for 10 years of MSSP. So MSSP's Managed Shared Savings Program, and 483 ACOs in the country. So those were the two highlights of the conference. But then, of course, a lot of things they went over. ACOs, of course, all this comes from the Affordable Care Act of 2010.
I mean, I think it even comes before that. If you are unlucky enough to remember the overnight babies in 1990s and the HMOs, that's been the fear of behind the ACOs, right? People were afraid in 2012 when this was coming out that the ACOs were going to limit beneficiary choices and provider decision-making, basically become the HMOs of 1990s. And I'm glad to see that that didn't pan out that way.
Okay, yes, absolutely. So, I mean, they're priding on the fact that they have been able with ACOs, that model, to advance health equity, support high quality person centered care, promote affordability, sustainability, and the goal of having all providers accountable by 2030. So this is.
I think at this point CMS also have been matured enough that they know what they're doing and they are pulling the right policy levers at the same time to prevent like outcomes as limited beneficiary choice or decision making or physicians controlling to keep costs down, if that makes sense.
Yeah, totally. So is again that equation, right? And we will keep coming back to this equation, which is value equals quality divided by cost. So no matter how you work on it, the idea is to have a higher value, either with less cost or with more quality, or both. So yes, I really wanted to ask you about this. So they actually even compared ACOs performing better than physician groups participating in MIPS, and this is on patient experience and performance measures. So that to me sounded like, wow. I mean, we're looking at ACOs being like further ahead. But then, what do you think of that?
I mean, MIPS necessarily have never been shown to be associated with better patient outcomes. But I think a lot of people are in MIPS, so you really don't have a good control. B, you're looking at cohorts, basically, and then in a cohort setting, there's too many variables, right? You have too many confounders. So some physicians will be dealing with more complex work. Some groups of patients are more underserved, so they're inherently higher risk. So it's hard to show any significant association here. Second thing, as I like to always say, is that the correlation doesn't prove causation. So even if it is associated, then what? And then the third thing I can say to that is that they compared it's sort of apples to oranges, because ACO is sort of like a one-stop shop, like an HMO. So they are handling their own. Just because a physician has a good MIP score doesn't necessarily mean if their handoffs are good, or it doesn't necessarily look at anything outside of that spectrum per se.
Mm-hmm, mm-hmm. All this is kind of like, I mean, of course, Medicare is federal, right? So everything is made public, and that's how we are able to know. Basically, it's if it was an insurance company, I mean, they won't make public their strategy or their model, because it's all for profit. So here we're looking at an insurance type of model, but since it's taxpayer money, we get to know what they're doing, and they publish it, like in this New England Journal article, which also highlighted that they're experimenting with different models, which is the normal thing to do. It's just like any shop would not have one way to do things. Very basic. I mean, if you're making cookies, you're making it to make money, you probably don't have one recipe. So same thing. They have different models, and they have some models that have been effective. And of course, the easiest way to look at something being effective is if it saved money or not. And the pioneer investment and the advanced payment models, the pioneer and the investment models have.
So Pioneer basically allowed the providers to coordinate care to move more rapidly from a shared savings to a population-based model. So I think Pioneer was never here to stay, but sort of to bridge the gap. And it ultimately did what they were planning for it to do. It led to reductions in ER visits and inpatient admissions. So I think that's the another goalpost, that we need to keep these people away from the hospital.
Yes. So so those models have been able to perform. Other models have not performed, and effectively, like you're saying, that they have also been able to see that the shift from a savings purely financial to a population-centered model resulted in reduction in ER, reduction in those outpatient becoming inpatient admissions. So what is your idea on this shift from savings, pure savings type of thinking, to a population-centered thinking?
I mean, you can't have one without the other. Again, I keep coming back to AAA. You can't really have savings without sorting out the population health, because if your people are sick, where are you going to save? Are you I like to tell people this, that are against everyone having insurance or giving people an opt-out. We do not let people die out on the streets. EMTALA is the law of the land. So if you go to an ER, you're going to be getting treatment no matter what happens to you. So if you're uninsured, the ER is going to be footing the bill, and ultimately the taxpayers are going to be footing the bill. So it is way easier to give someone insulin than to treat them after they've been in ketoacidosis. It is way easier to manage a chronic condition than to wait for it to get to the point of them calling 911, going to a hospital, racking up $1 million bill, and sorting it out. So those come hand in hand. If you can't manage your population health, you cannot, in good conscience, save money.
Of course, of course. So again, the social determinants of health in the city. Of course, we have, in New York City is like we always mention New York City is like a world in itself, which is not false. I mean, if you go to certain parts compared to others, it's completely different. But then we can also talk about rural areas, rural America. I mean, America is so vast, right? I mean, it's there's disadvantage, but then there are people who are just living out there, and they don't have the same access as if they were living in urban areas. So this has also been the focus of the innovation center to include those
Correct, and
disadvantaged
hopefully
populations.
I mean, hopefully the telemedicine will help with this. And the issue is not that these people don't have access either. A, there's no population to support the physician being there. B, these critical access hospitals are dying. So with that takes a lot of local jobs and just the globalization of medicine as well. I guess a lot of hospitals are just consolidating. And C, it is hard for a well-educated physician to be satisfactorily employed in a rural place because the social aspect of the life doesn't necessarily match what they expect. So that's the difficulties there. But with, I think, expanded PA access, nurse practitioner access, as well as the
Absolutely.
telemedicine waivers, I think it's just going to go better and better every day because it is way easier to have a rural patient have a telemedicine visit with a nephrologist going over the labs and prescribing dialysis and get dialysis there than to expect the nephrologist to either live in that community or drive there or expect the patient to drive there.
Absolutely. Yes, we mentioned that in the last podcast, and yes, nurse practitioners in New York have now expanded powers, matching their training, and same thing for PAs, right?
Mhm.
Yeah. One more thing about the COVID and the social determinants of health. So that's going to be driver, right? So coming back to what you mentioned about the contracting, the ACO Reach. Can you talk a little bit about that? I mean, the contracting and how they're going about thinking about the new way to contract.
Sure. So basically, we were talking about the Pioneer program, and then basically there was also an ICO investment model. So provided advance payments to participating organizations so they would make the infrastructure investment needed. Ultimately, they were hoping that this would be recouped by CMS by means of earned share savings. So they were saying, here you go, here's the money, you go build the infrastructure. When you make the people healthy and you have savings, we'll take our cut from there. This basically provided a lot of rural and underserved communities signing on to be ACOs. There was, I believe, close to 400 million in net Medicare savings up until 2016 to 18. So now they're testing this REACH model. So it's a new risk sharing arrangement in traditional Medicare, but there's flexibility for beneficiaries. So they can receive in-home care management.
Okay.
And then there's less and less reduced administrative burdens for providers on quality of care and cost. So basically, they're learning their lessons that people get burnt out by the administrative hurdles or a lot of rural, less fortunate, chronically diseased patients are having difficulty access going somewhere, driving. They may not even have enough food. Even if they get their insulin, they may not have a reliable fridge. So there's a lot going on behind the scenes. So basically, that's all the goal, to align strategically with the 2030 that there's high quality, accountable care for all Medicare beneficiaries.
So additional flexibility for beneficiaries, in-home care management, increase in health equity,
Correct.
and decrease in administrative burden.
Correct.
So that's great.
Exactly.
That is. Can you talk a little bit about the billing? I have more than what I should heard from providers that they have a quote unquote fear of billing, and that is maybe justified, just because you think you are doing good that way. Can you take that question and just expose it as to you are the expert in Medicare. Tell us, what do you think about this whole idea of not wanting to bill and bill for, of course, we're not talking about abuse here. We're talking about billing for the right use, please.
I mean, okay. So just because you're afraid of billing or just because you're afraid of an audit shouldn't mean you shouldn't bill. Do you not file your taxes annually? Are you afraid of an IRS audit? I mean, it's just something you gotta do. If you get audited, documentation is key. So I always tell people your first thing is to document. And the second thing is that people are not computers. We're all gonna make mistakes. The goal of these audits is not to penalize you for one simple mistake. The goal of these audits are typically to weed out those that are doing this in a fraudulent pattern and are trying to have bad thinking or are trying to defraud the program. So if you're doing what you're supposed to do, if you're billing for services provided, and if you have good documentation of exams, this and that, I don't think you should be worried about anything. If you get audited, all your data is there. They're going to look at it and they're going to say, oh, this should have been this maybe, or they're going to say you're good and be done with it. So couple maybe things that people may be worried about is just this E&M clinic visit codes. The bill for what you do. Don't try to bill 5 minutes extra in the greater scheme of things. It's not going to change anything. There may be diagnosis codes that don't reflect documentation. That's the big one. As I say, if you make a diagnosis, just please make sure you document. Like, I know we are all time crunched, but sometimes I see patients with, let's say, I don't know, that was the recent one, testicular hypofunction, diagnosed, ICD-10. Okay, I'm looking at the documentation. There is no mention of a genitourinary exam done. So just really, you're examining someone for a testicular hypofunction and you're not going to give them a GU exam. So just copy and paste the exam notes. It's obvious. Mm-hmm. Just like spend a couple more minutes with that. Mm-hmm, mm-hmm. And then ultimately that may also be that like there may be some modifiers that don't reflect documentation, surgeries that aren't appropriately documented. So again, what I'm saying is as long as you properly document, you have nothing to worry about.
So one thing I wanted to tell you, I was reading on this. So the Ratchet Effect. So what's the Ratchet Effect? It's when somebody who works and is subjected to payment based on performance will consciously limit his performance in order not to exceed the expectations. Because if he keeps performing, then they'll be like, oh, that's the new benchmark, so you should be doing this. So that Ratchet Effect, which is found in all industries, is what's kind of like happening in care, and that should not be the case. And then you have the MIPS, and then you have the Medicare star ratings, which it's part of the game now, and whether you like it or not. So getting to work on your MIPS and having a good Medicare star rating requires, resources and effort. So if the billing codes are dedicated for chronic care management, is because there's a logic to it. It's not just because it's there and to be used sparingly. Of course, resources have to be used sparingly, but here is incentives in order to do well, because down there is that MIP score, which is all too important because it's double-sided. All contracts are going to be double-sided 2024, right?
I mean, correct. So they're basically trying to. So the issue with the MIPS, as you say, or the ratchet effect was rebasing. So benchmarks are recalculated during contract renewals, what was observed. So basically, people have sort of been incentivized to take care of disadvantaged populations.
Yeah, absolutely.
So if that happens, people are saying, why should I risk taking care of that person and then risk getting my score cut, right? So with that, I mean, you can bill for chronic care management. So if you're dealing with a really complex patient, you can bill accordingly. There's nothing stopping you from doing that. And ultimately, if everyone's taking care of these patients, because these are rolling benchmarks and comparing everyone, then I don't think you have anything to worry about. And just because someone's disadvantaged doesn't mean you can't necessarily treat them. It doesn't matter if their diabetes has been out of control for 10 years. It takes simple steps to get it back in check, right? I mean, I was reading a paper just a day or two ago just appalling the rate of statin uptake in those with CAD. Like it's such a simple thing to prescribe someone statin to make sure they take it. They have any muscle aches or stuff like that, just to check for side effects and sort it out.
Mm-hmm. So you talk about benchmarks. So the strategic benchmarks are getting adjusted. And secondly, we have populations that cost more due to social determinants of health, due to geography, whatever. But the idea is Medicare wants everyone to be successful, all providers, right? So the help that's being offered is also to have everybody meet their quality goals.
Correct. I mean, ultimately, CMS is not out to get you. They're a gatekeeper. They want to make sure everyone's healthy, and if anything, they want you to make more money, because if you make more money, they will save more money.
So the traditionally disadvantaged, the idea is to ensure higher quality, and going forward. So CMS is going to keep testing with these new ideas. We can imagine it's going to be new things coming all the time?
I would think so. I think there is just continuing. It's data driven, so they analyze, review, move forward. Analyze, review, move forward. So I don't think any country in the world has achieved a perfect system. And given the restrictions on government-paid healthcare, it's looking tough and tough. So I think going forward, it's just going to be the same. But at least we know where we are going, right? We are on the bus to Abilene. We don't know which road we are exactly going to take, but we know where we are going, which is AAA.
And in population health, so what, like in our case, at CCM Health, if the providers are properly ready to receive services, what are the solutions that we offer to make them to make them receive even more of all the advantages and achieve all their targets?
Can you clarify the question?
So I'll take the question and then you will see where I'm going. So we have the solution of the chronic care management. So,
okay.
So that is the big one, right? And then the RPM, which is using very precise technology. And
right.
then the COCM, which is the behavioral health. All this is in the context of social determinants of health, pandemic, very important. And most providers, they love the idea of to be able to manage their patients for behavioral health. And then you have the quality. We are talking about PCMH. We're talking about, your quality measures. We're talking about MIPS. And then, of course, the regulatory consulting. So all these things that we offer is all in line with what Medicare is wanting us to do as far as individual providers, network of providers, and even in the context of an ACO, all those
Correct.
ACOs out there.
Yeah, and then I agree with that. From a CCM perspective, I think it's just here to say, and it's going to get progressively bigger. Again, a lot of it, I think, will be long COVID will play a big role. And the more grounded it becomes, because there's not necessarily a list of diagnoses that can build for CCM, right? So basically, it's any chronic condition. So the sky is the limit here. And then ultimately, I think by implementing a CCM program, especially with the help of a partner, that practitioner will grow the skills and the internal processes for population health management, and then they will be receiving fee-for-service. So it'll probably affect their MIPS scores and get them better suited to the U.S. healthcare from a CMS perspective in the 2020s and 2030s.
Absolutely. Social determinants of health. We'll talk about that in more detail coming up in the future. I think we are up for time. Dr. Baran Erdik, thanks for joining us. We will be back in a fortnight. Our guest will be Dr. Friedel. Thanks for joining us, everybody, and stay safe. Have a good rest of your day.